My presentation is on suicide rates and prevention strategies in low and middle-income countries. Suicide is a public health problem. Suicide rates have increased over the past 20 years. Suicide accounted for 1.8% of the global burden of disease in 1998 and is expected to rise to 2.4% by 2020. Suicide disproportionately impacts low and middle-income countries. Suicide is preventable, but currently only 28 countries are known to have national suicide prevention strategies. Suicide is a global public health problem that disproportionately impacts low and middle-income countries and has largely gone unaddressed until recently. Stigma, laws, and a lack of both resources and awareness for suicide prevention often result in individuals not seeking help. Suicide is a complicated topic, with no single cause easily attributable to the act. A combination of interacting environmental, genetic, biological, social, and psychological factors influence suicidal behavior. Suicide is preventable. The most effective prevention efforts involve a comprehensive, multi-sectoral approach. Methods used for this project included literature searches of PubMed, Google Scholar, and Google, utilizing the keywords suicide rates in low and income countries, suicide prevention, and suicide statistics in English for publication years 2005 through 2019. Suicide is the 15th leading cause of death globally. 800,000 people die by suicide each year. That is one death every 40 seconds. More people die every year by suicide than by homicide and war combined. For every person that completes suicide, it is estimated that 20 other people attempted it. While these statistics show the staggering numbers of those who have attempted or committed suicide, they do not show the much larger portion of family, friends, and community members that are impacted by suicide in both the short and long term. While global annual estimates for suicide are 800,000 people, the actual number may be far greater. Obtaining accurate statistics regarding suicide is challenging for several reasons. Vital statistics records are of varying quality. Reporting rates may not reflect the actual cause of death due to stigma or due to inaccuracies in coding. The figure on the left shows age-standardized suicide rates per 100,000 people for both sexes in 2016. In this graphic, rates in much of Africa do not appear in the highest levels. The graphic on the right shows the quality of vital registration data for causes of death, including suicides. The same areas in Africa that reflect less high rates also reflect very low levels of data quality. Low and middle-income countries are disproportionately impacted by suicide. And again, these numbers may be below the actual rates due to challenges in obtaining accurate data. 79% of suicides occur in low and middle-income countries. Low and middle-income countries comprise 8 out of 10 of the countries with the highest prevalence of suicide. Globally, the most common methods of suicide are use of firearms, self-poisoning, and hanging. In low and middle income countries, self-poisoning is the most common method, often with pesticide, but the item of poisoning can vary geographically. Low and middle income countries are disproportionately impacted by suicide for a number of reasons. Low and middle income countries have fewer economic and human resources. Low and middle income countries often lack the infrastructure necessary to support policies and programs. In some low and middle income countries, suicidal behavior is considered a criminal offense. Stigma associated with suicide can prevent both seeking help and accurate reporting and record keeping. And a lack of awareness regarding suicide as a problem and available resources for prevention. This combination of a lack of infrastructure and resources further stresses systems not well equipped to meet the needs of their citizens. The World Health Organization has identified several effective means of suicide prevention. They include training of healthcare workers in the early identification and treatment of mental disorders and suicidal behavior, restriction or removal of access to means of suicide, school-based education and interventional programs, the introduction of policies to reduce the harmful usage of alcohol that is often associated with suicide, encouraging the responsible reporting of suicide by the media, and the provision of follow-up care and community support for those impacted by suicide in both the short and long term. The World Health Organization has provided a framework that can be customized by individual nations. Initial steps involve identification of stakeholders, followed by seeking of a political commitment, undertaking a situational analysis, addressing stigma, resource assessment, and increased awareness. The next step involves a clear statement of objective, risk and protective factors, and election of effective interventions at different levels, including universal, selective, and indicated. Finally, this is followed by improvements in case registration and the conduction of research and ongoing monitoring and evaluation. The following are several examples of efforts towards suicide prevention in low and middle income countries. Sri Lanka saw a rise in suicide rates that followed the relaxation of trade restrictions of a highly hazardous pesticide. In the graph, you can see the mostly continual increase in suicide rates up until the peak right before the year 2000. Then, the rates continually decrease. The decrease in the graph coincides with the introduction of pesticide regulations in Sri Lanka. Those regulations resulted in the greatest reduction of suicide rates to date. Guyana has one of the highest, if not the highest, suicide rates in the world. Stigma and myths associated with suicide have played a large role in individuals not seeking treatment. In response, Guyana launched a public health campaign that utilized the media to raise awareness, myths and reduce stigma. At the same time, they increased training and identification of treatment of mental illness for non-specialist doctors in 10 regions of Guyana, thereby expanding those available to provide mental health resources to citizens. In Bhutan, in response to increased incidents of both mental disorders and suicide, they introduced a 3-year action plan towards suicide prevention. The multi-sectoral plan involved a strengthening of policy, mitigation of risk factors, promotion of socially protective measures, reaching out to those at risk for and affected by suicide, capacity building among gatekeepers likely to interact with and identify those at risk of suicide, increased education, and improvement of the suicide information system to help inform future policy. Suicide is a public health problem that is preventable and disproportionately impacts low and middle-income countries. A comprehensive, multi-sectoral approach is key to effective prevention. As evidenced by the examples given in the previous slides, interventional strategies are variable and should be customized to best meet the needs of countries and their constituents. Implemented strategies following a comprehensive multi-sectoral approach have shown both success in the reduction of suicide rates and promise towards future reduction of suicide rates in low and middle income countries. Here are the works cited, utilized throughout the slides in this project. I hope that you have found it both interesting and informative. Thank you.